So welcome back to Rnpntutors USA. Today we're going to continue talking about maternity nursing, and we're going to talk about pregnancy-induced hypertension, or PIH. Now, pregnancy-induced hypertension is a condition that is sort of characteristic to pregnancy. It doesn't happen outside of being pregnant, and what happens is the pregnant woman gets hypertension or high blood pressure. They also have protein in the urine, and they tend to start swelling up or have edema. Usually we see this more with first-time moms or primigravida who is often age extreme. So let's say the individual is younger than 18 years old or older than 40 years old. That could be one of the reasons why they're developing pregnancy-induced hypertension. Another reason why a mom could be developing pregnancy hypertension could just be family history. It could also be related to a protein deficiency. PIH can progress from just having high blood pressure, some protein in the urine and edema, to what we call mild preeclampsia. What that means is the patient's blood pressure will increase, especially the systolic above 30 and diastolic increasing even above 15. And that's a large increase in blood pressure, by the way. And so mild preeclampsia occurs with some edema, +1, +2 edema, usually of the upper and lower extremities, hands and feet. And we'll also notice that the patient starts to have very high blood pressures with up to 3 grams of protein in the urine in a 24-hour collection. That's a lot of protein in the urine. Now, if we do not reduce stimuli and start to identify this problem and start to address it, then mom can progress to more severe preeclampsia. And with severe preeclampsia, mom is going to have edema, but instead of just having edema of the hands and feet, the edema is now generalized and will now be pitting. So when we palpate or depress or make an indentation on mom's skin, wherever the edema is, it will pit, or it will take time for the skin to return or not at all. Other things we note about severe preeclampsia is that the blood pressure goes above 160/100. We'll see proteinuria increase up to 5 grams in a 24-hour collection. Mom will start to have headaches, abdominal pain or epigastric pain, visual disturbances, and urine output will start to be reduced. Now we have to do something about this. Another thing we notice with severe preeclampsia is hyperreflexia. The deep tendon reflexes become exaggerated. So when we hit, let's say here, or the knee jerk, we'll get an exaggerated reflex. Now, if we don't control our patient at this level, it will progress to eclampsia. And eclampsia is worse than mild preeclampsia, is worse than severe preeclampsia. Eclampsia is where we have the patient having generalized edema, it's pitting edema. They're also having protein in the urine. They have extremely high blood pressure, and now they're having seizures. They can develop altered mental status and go into a coma, as well as they start to establish lowered platelets. If you know anything about the body, if we start to have lowered platelets, altered mental status going into a coma, high amounts of protein spilling into the urine, then we know that this patient will start to develop liver issues, and we'll notice these liver issues by assessment of the liver enzymes. So they'll start to have alterations in the liver enzymes. And these are not good signs. This is an exacerbation and a complication and can lead into HELLP syndrome. So what do we do for mom? Our first intervention is that mom needs bed rest and lowered stimuli. We must monitor the vital signs. We must monitor her weight. We have to pay attention to strict intake and output so that we can monitor her urine and also measure for the protein in the urine. We have to do continuous fetal monitoring. We have to do continuous uterine monitoring. We have to monitor deep tendon reflexes. Remember that even when mom is on seizure precautions, the only cure for eclampsia is really to deliver this baby. Even after the baby is delivered, we continue seizure precautions for up to 72 hours after delivery because mom is still at risk for seizures. Now, in order to assist with the blood pressure, we must administer, usually what is administered is IV magnesium sulfate. Magnesium sulfate is a drug that will work to vasodilate or cause more blood flow and tissue perfusion. It will cause mom's blood vessels to relax because it will relax smooth muscle tissue that's within the blood vessels. that will reduce vasoconstriction. It will cause maternal vasodilation, which will also cause increased tissue perfusion, and that will then lower blood pressure. Now, the drug is good at lowering blood pressure, but of course it has other effects. It lowers the respiratory rate, so we must monitor vital signs. It increases the pulse, so mom does get more tachycardic. We must use an IV pump, must run mag sulfate PVAC, must monitor the deep tendon reflexes. If the deep tendon reflexes are no longer, when you test for them, you do not elicit a response, this means that there's too much MAG, it's toxic, it's not effective anymore. Another thing to note is that if you're infusing mag sulfate, you must have calcium gluconate on hand. That's the antidote for mag sulfate, because if we start to make mom toxic, we will need the antidote to reverse the effect. And calcium gluconate is the antagonist to magnesium sulfate. If we do not deliver this baby and reduce these symptoms with these interventions, mom can progress into what we consider HELP syndrome. And this is where we have hemolysis of red blood cells, we have elevated liver enzymes, we have low platelets, and it can lead to maternal death or the fetus's death. This is very important for us to remember. So this is our quick video on pregnancy-induced hypertension, preeclampsia, severe preeclampsia, and eclampsia. One of the factors that you are monitoring for when mom has PIH or preeclampsia is abruptio placenta. Watch our video on abruptio placenta. Don't forget to like, share, subscribe, and join us again for another quick video on nursing, Rnpntutors USA.